Good morning, everyone. Thank you, Carly, for the nice presentation. So I will talk about the cone repair after the Starnes procedure, but before I would like to make some comments about that case. Of course, was a patient that was referred to us after the Glenn procedure. So that kid was very sick during the neonatal period, and she was saved by the Starnes procedure. But if she was here after 6 months, we would not go forward to the Glenn. We would do the tricuspid valve repair, the Starnes take down, the tricuspid valve repair, and a biventricular repair. So most of our patients are coming to us after the Glenn, and that's the reason we have just a few cases of biventricular repair. So since 2019, we are doing the cone repair after the Starnes procedure, as we previously published. And thinking later on the cone reconstruction, the rehabilitation of the right ventricle, we also introduced some maneuvers to facilitate the next steps, like covering the pulmonary valve with a PTFE patch. So later on, it's possible to remove the patch and do the repair in the pulmonary valve. Also, to avoid the heart block, we do use the PTFE patch in a higher position in the right atrium. Here is a case that was performed, the fetal echocardiogram made a diagnosis of severe tricuspid regurgitation, severe pulmonary valve regurgitation, and the kid was born in a very poor condition, so it was not possible even to do a postnatal echocardiogram. This kid went immediately to the OR to do a Starnes procedure in another institution. The kid was then taken to us after the Glenn procedure, and the surgeon had sutured the pulmonary valve and destructed the pulmonary valve. But the kid was alive, and she came to us later on. This is the Starnes patch, the ASD. So here we are doing the Starnes takedown of the patch. We need to do it very delicately to not damage the leaflets that are underneath the patch. So that's the reason we advocate for the use of the PTFE instead of a pericardium or autologous pericardium or even bovine pericardium. Here, the patch was removed already. We are placing some sutures to expose the tricuspid valve anatomy. We can see that it's a severely displaced tricuspid valve. The anterior leaflet is mobile, so it's a good situation. We are doing the delamination of the anterior leaflet. So we need to be very careful and gentle. We can see that was completely attached to the muscle, and we are shaving the leaflet basically from the right ventricle wall here. So we move forward to the lateral side. I think this is the most important part of the procedure when you are delaminating the valve, because you usually don't have enough tissue. It's not too much tissue, and the patient is a redo operation already. So here we move towards the medial portion, delaminating the area of the septum. We can see we don't have much tissue in the septal area. And here we are cutting the inferior portion of the leaflet, and then we start reconstructing the cone. Here I'm delaminating a little bit more the septal papillary muscle. This is to make it more mobile, the leaflet more mobile. cutting the distal area to avoid stenosis. And here we can see the distal linear attachment of the anterior leaflet that Dr. Bob Anderson referred to. So we cannot see any papillary muscle in the anterior leaflet. So in this case, we need to create fenestrations to allow the inflow after the cone is red. So we are enlarging the fenestrations here, creating another one. And here we start suturing the leaflet to the annulus. And I call attention because after the Starnes procedure, usually we don't need to decrease the size of the annulus, the tricuspid annulus, because the patch of the Starnes procedure already kept the annulus in a smaller size. And this patient had already a Glenn procedure, so we need to understand that this valve will be a little bit smaller than usual, but the flow that will go through it will be just the inferior vena cava flow. Here we are suturing the septal area to the inferior leaflet. And then we suture to the annulus. And in this case, we opted to enlarge the septal leaflet with an autologous pericardium patch, fresh. So it's the patient's own tissue to complete just 25% of the annulus in the septal area. This is to increase the mobility, the excursion of the septal leaflet to have a competent valve at the end. So we place a patch that's a little bit redundant, but we need to understand that the skid will grow and the patch will shrink a little bit immediately after the reconstruction. Here we are closing some orifice there, suturing the patch. So the surgery takes a little bit long, usually 2 hours, to reconstruct the valve and reconstruct the pulmonary artery, the RV to PA connection. In this case, like I said before, the surgeon had sutured the pulmonary valve leaflets because it was a circular shunt, so he completely destroyed the pulmonary valve. And then we need to recreate the RV to PA conduit at the end. Finishing more orifice, closing more orifice in the tricuspid valve. And then we are testing the valve, and we can see the right ventricle is filling, and the valve is completely competent. Now we are opening the RVOT. And then opening the main pulmonary artery that's far away. And then in this case, we opted to use a PTFE valved conduit. It's a 16 millimeter conduit that is 3 leaflet. So we will suture first in the distal to the pulmonary arteries, and then proximally to the RVOT. Finalizing the suture. And to close the ASD, usually we use a PTFE fenestrated patch We create a center of fenestration, usually of 4 millimeters. So if there is any RV dysfunction in the post-op, or if the right ventricle cavity is not big enough, then we will have some right to left flow and not low systemic output. This is to prevent low systemic output. Here we are closing the wall of the right atrium, and then the heart start beating. And then the post-operative echo showed a good tricuspid valve function with almost no regurgitation and no significant gradient. This is our last publication, and in this paper we explain all the details how we prefer to do the surgical treatment of critical ill neonates with Epstein's anomaly. Thanks so much. Now I will call Dr. Carly again to talk about another case, interesting case with Con.